Hello and welcome to the EBUS lecture. I'll start this session. We will have a 3 short lectures and you will have enough opportunity thereafter to ask your question or maybe give your comments. I'm sure that you already have experiences EBUS. It's not a completely new technology, although in the last time it saw many new developments in this field. I will talk a little bit about EBUS, advanced imaging modalities, which you can find in the older YUMI processor series 2, and now even more advanced in the new type of the processor YUMI 3. So it's my name, my conflict of interests. You see here I have a lecture for Olympus. And what I'm going to talk about today is a little bit about mediastinal lymph nodes, what we can find in these mediastinal lymph nodes, and then how these additional imaging modalities like B mode, Doppler mode, elastography, tissue harmony echo, and all features in YUMI 3 can help us to avoid complications and to get better diagnostic yield. So let's start a little bit with the lymph node. I know that you are very familiar with the anatomy of the lymph node, but I can't resist to show you once again the bigger picture. The idea is basically that the lymph flow comes to the lymph node from the lymph node periphery, but vessels are coming from the center. So this is vitally important when we have the initial small metastasis, which usually find just in the very periphery of the lymph node. This is important when we stick the needle when we are staging, and that we should not see big vessels coming from the outside, because it's a bad sign, as I will show later in my presentation. So lymph nodes can be affected from many different diseases. I won't go into very details. It's not just malignancy. There are many benign causes. And also important thing, sometimes sarcoidosis or basically sarcoid reaction can be attached to the early lung cancer or breast cancer or lymphoma. And if we find a granuloma without a necrosis, in connection with cancer, this is usually not a bad sign, because these lymph nodes rarely harbor a small metastasis, although they are AVIT and PET-CT, and we have to diagnose them properly. Let's first see what B modes can show us. So B mode can show us when we see a lymph node, we get the first impression. Is it enlarged? Is it not enlarged? Does it have some necrosis inside? Does it have a harder part, a softer part? What's border? What's the shape, basically? Is it round? Is it oval? And many authors in the past have tried to make some story out of it. For example, the idea was, let's just observe the lymph node and spare the needle, don't puncture it, don't harm the patient, and maybe we will have also good results. Although here are many data collected, don't read the numbers, it's just for illustration. I just keep the whole story about this B mode is that B mode is not accurate enough to replace cytology. So at the end of the story, we always have to stick the needle in the lymph node. But important is what to expect and where to put the lymph node, to needle in the lymph node. Because we see many different things. We also find sometimes the big vessels into inside of the lymph nodes, especially subcarinal often harbors bronchial artery inside of it, which can be a very big one, especially with the patients with chronic bronchitis and with bronchiectasis, where these vessels are usually hypertrophied. And also in the lung cancer can happen as well. So you see many different features and you have the impression. So if you are quite confident that the lymph node has benign features and your puncture at the end is also benign, you can be quite confident that your result is okay, and the patient maybe not need to be pushed to another invasive procedures like mediastinoscopy if you're talking about lung cancer. But if you find it suspicious and your result is cytologically negative, then keep this suspicion and maybe plan the next procedure. That's basically the whole story about that. So what I wanted to tell you that we have 2 curves in all these studies. Everything is approximately similar. One side is specificity, one side is sensitivity. If you want to be more specific, then our sensitivity drops. If we want to be very sensitive, then our specificity drops. And when these both curves come together, we get our, I would say it, a sort of accuracy or the possible diagnostic yield of B mode. And as you can see, it's around 70, 65%, which is 20, 15% less than cytology. So that's basically the range of B mode. So here are some additional numbers, but I won't lose time going through all these things. We also have some meta-analysis, which all show approximately the same, that B mode cannot replace cytology. What about Doppler mode? It's an additional and welcome feature. At the end, I'll show you a nice case where the Doppler can be very beneficial when you use it. But again, it cannot make a diagnosis. A few studies were also published which show that if a lymph node has a lot of vascularity inside, and if the vessels are coming through the capsula from inside, that this is a bad sign for the lung malignancy. Here is illustrated. Grade 1 and grade 0 are usually benign features of the lymph node, but grade 2 or 3, and maybe this inflow sign, which I just mentioned, can increase the possibility of malignancy of involvement in the lymph node. So again, we have this meta-analysis and shown how accurate this is, but it cannot again replace the cytology, and I will just go and skip it further. The next feature, introduced several years ago, is elastography. Elastography works on the principle which is like it can recognize hard objects inside soft objects. So if you have a cherry cake and there are some bones inside, if you press it and look histographically, elastography will show them as a blue dots. Elastography is usually shown on the spectrum from red to blue colors. And the more blue the thing is, we have these different ways how to analyze our histogram. But I'll go one by one if you want to take actually a remark. But I go one by one. The basic idea is the more blue is the lymph node, the more probably that is malignant in the context of lung cancer. But we can also have hard lymph nodes in other diseases. For example, the old sarcoidosis, when lymph nodes are fibrosed and there's a lot of scar tissue, or after tuberculosis and so on, we also have blue lymph nodes. So unfortunately, this method cannot distinguish what's malignant, what's not malignant, but only hard lymph node from soft lymph node. And basically, lymph nodes should be quite soft, quite green and yellow as on the upper field, and maybe a little bit of red, not too blue. If they are too blue, they are pathological. And each of these features has its own sensitivity. And this is another mode how to analyze elastography, that we analyze the histogram of all the colors which are captured on the image. And also there are some software possibilities. Then you cut out a piece which is of interest of you, and then you analyze how blue or how red it is, and then you have some distinction between what is hard, what is soft, what is possible malignant, what is possible not malignant. We also performed and used the strain ratio when we compared the hardness in the lymph node with the hardness of surrounding reference tissue. And there's also a difference between benign and malignant lymph nodes, quite striking one actually, but in all cases you cannot differentiate accurately, again, is a positive or negative. So here is maybe a short example. I'll try to activate the video. Yeah, you see here two lymph nodes, they are pretty blue. They both are very hard. Although they are not big, they have malignant features. They are round, they are hard, and at the end they prove to be malignant. So you see now in colors how they look like, and now I show how you measure the strain ratio. You make an area of interest within lymph node, then you select the reference area, which is always debatable what is the best reference area, and then you compare stiffness in one area with another area, and you get a strain ratio, which is here 22, which is pretty hard. And again, we have meta-analysis, data, and at the end, when we go together for all this, sensitivity and specificity are again lower than cytology. And the end of the story is you have to stick the needle inside if you want to have accurate diagnosis. This is a very nice study. Basically, there were two studies published where elastography can be helpful, and what mode of analyzing of histogram is the most relevant. Authors compared the modified Tsukuba scores, that means color impression, then histogram mean, and the strain ratio, which I showed to you. And at the end, they concluded that the strain histogram mean is slightly more specific and sensitive than the other methods, and where to use this. So they thought like this. If we have PET-CT, and we have PET-CT positive lymph node and PET-CT negative lymph node, then we perform bronchoscopy and make this elastography. And if a PET positive lymph node has a negative elastography, the possibility that it is malignant drops down radically. And if our cytology here is negative, we can believe this result. But if it's positive, it's positive. And here again, if you have PET negative lymph node, but elastographically very suspicious, either we get malignant cells inside and we confirm that it's really malignant, although not enlarged. But if we don't get representative sample, we shall keep our suspicion that this lymph node is really something wrong with it and proceed with further. But if we have everything negative, our post-test probability is very low, and this helps us a little bit in decision-making when we have the complete workup of the cancer patient made, and still cytology is not very conclusive in these cases, because even cytology, be honest, we cannot puncture each patient 100% accurately. And again, another, the same basically story, when they divided PET and size of the lymph node, that means measured on CT, and again, elastography. And at the end, as you see, elastography changes a little bit the odds ratio, what we really have. So this is important in the cases when we have unconclusive cytology after the puncture, where to keep our suspicious high and where we can be confident that our result, negative cytology, lymphocytes and something, are really the true result of this. Now just a few words about tissue harmonic echo. It is not a major feature actually in the EBUS ultrasound. It's actually additional thing. It is a physical phenomenon where we put our energy, ultrasound energy, into the tissue, and it usually has, I will very simplify the whole story. It concentrates a little bit more in the center of the ray, of ultrasound ray, and it amplifies, and ultrasound gets higher frequencies, higher harmonic frequencies. So if you have 6 Hertz, the harmonic frequencies are 12, 44, 24, and so on. And these new frequencies which are developed in the tissue also reflect back. And if the processor is able to collect these additional frequencies, the central of the EBUS B mode is more accurate and presents us more sharp and more resolute image. But as you see, this is an additional feature which doesn't make decisive difference. But again, if you use it, and if you have this in your armamentary, it can give additional edge that you can see, especially in the field where you don't have so resolute and nice image that you see something more. So here is a little bit difference. I hope that the video starts. Should show a slight difference when we change the normal B mode to the tissue harmony echo mode, and the center of the image is slightly more resolute and sharp than in classical presentation. But I'm sorry, I think that these movies were not copied properly. Okay, now what offers the new YUMI free processor is that elastography here is a little bit more easy to acquire. When we use elastography in the usual daily practice, we are often limited by how nice B mode we are able to create. Sometimes patient moves a little bit, or we don't have good contact with the bronchial wall, and also sometimes pulsation in the tissue by heart or by breathing, which are necessary to create histogram, are a little bit less resolute, and the elastography image is not the best one. So in the new YUMI free processor, this is solved that way, that even smaller amplitudes are more accurately transmitted into the elastogram image. And since many times we don't have all the time the elastogram inside, when you press the pause, it automatically jumps back to the best possible elastogram image, so you spare some time, you don't search this manually. So this is maybe a a feature which spends you some more time. And the next feature which the Olympus didn't have before is this strain histogram, which proved to be maybe even more accurate in analyzing the lymph nodes than the strain ratio, which I showed you before. So we have now even the elastogram in the lower left field of the image. So maybe now the last and the most important thing, where is this, what is the practical value of all this stuff which I showed you just now? This was a lot of theory, a lot of, a good technology, but not good enough, but where this in practice really takes place. So I'll show you a case of one patient who had a surgery for lung carcinoma 3 years before this situation. And he was followed up. There was no recurrence, but in one moment they performed the PET CT, and they found the avid area on the 4R lymph node, and there was a suspicion of local relapse of the disease. So the patient was sent to our clinic to diagnose it. It was just a small dot in the 4R position. All the rest was okay in this patient. And even if we analyze the lymph node, not the whole lymph node was PET avid, but just a part of the lymph node was PET avid. So now I think, now it works. So we see here the lymph node, which looks quite benign with the fatty hilum, but something is inside. A small ball, as you see it, is within the lymph node. So even when we performed elastography, it showed a clear positive result that this part of the lymph node is harder than the rest, and this is actually our target. It's waste of time to take biopsy from this side of the lymph node, which appears pretty normally, but we identified this target within the target, and we take a sample just from this small ball, which actually and we actually get a benign result. The pathologist says it looks like a granuloma, but from cytology he's not sure, and he said, okay, it's a little bit atypical. The case ended with this, that mediastinoscopically the whole lymph node was taken out, as you see it here, and it was indeed granuloma. It was not the relapse of the disease. So the point is that elastography can help us in accurate targeting. Either we have a small hard parts, could be also metastasis inside the lymph node, and we can target it accurately. And on the other side, when we have a big necrotic lymph nodes, when we puncture to get diagnosis, we avoid soft areas where there is a necrosis and bad cytology, and we find the areas of the lymph node or the tumor, whatever we puncture, which is hard, which is blue, and take sample from that area, and we are more confident that our sample will have a live tissue and vivid cells, which would bring the diagnosis up. So the next thing, I just mentioned this, that these diagnostic possibilities, a better selection of the target, suspicion of one node from the group of small lymph nodes, or to select the area which is more suspicious than the other. So this way we can increase our diagnostic yield of cytology. The other maybe also important thing is the Doppler mode in our new procedure. Everybody likes to do this in the recent year, is cryobiopsy of mediastinal lymph nodes. When we have unconclusive results after the first biopsy, or we diagnose a benign disease like sometimes lymphoma, sarcoidosis, or maybe all tuberculosis, doesn't give us the good diagnostic yield. And okay, I'll just skip it. The important thing is when we go into the lymph node, we want to see our cryoprobe where it is, and we also activate the Doppler mode to see whether some big vessels are around. Because if you see the probe is activated, it's freezing, and then we can pull it out and take a very nice and big sample for histology. The most important thing here is that sometimes in the lymph nodes there are quite big vessels, and imagine if you wouldn't check this lymph node and take just a cryobiopsy out of it, you may have a big bleeding, which would end with a hematomediastinum and the big complications for the patient. So the one thing to conclude is elastography is very useful in selecting the target, either a small piece within the normal looking lymph node or a viable non-necrotic part in a big tumor or a big lymph node. On the other side, when you do more invasive procedures like cryobiopsies or mediastinal lymph nodes, or even puncture with the big needles, check the vessels first to avoid complications and big bleedings. So thank you. This is the end of my talk, but now you're welcome to make your comments and also maybe ask some questions if you like.
Hi, I'm Ricky, one of the chest physicians from UCL. Just a quick question about the elastography. So how often in your usual clinical practice do you use it to target specific areas of lymph nodes? So I'm talking about sometimes you get this necrotic lymph node and you keep taking passes, and you don't get enough tissue. Is that an indication for using elastography?
I would use it. Actually, I use it quite often. And it looks like that. You select your target, you make the first puncture with the EBUS, and then nurse needs some 20-30 seconds to put out the sample, reprocess the needle, and you are waiting for the next puncture. This is the time when you can play with elastography, look the colors, select the better target. So it doesn't necessarily prolong the procedure, but while nurse is reprocessing the needle, you have opportunity to check all this area either elastrographically or with Doppler mode. And sometimes you find something that you change your practice, that you change the direction of your puncture, or maybe do something else as planned initially.
Thank you.
It's not always, but there are cases where it changes the course of the diagnostics.
Thank you.
Sorry, Alice, just a quick question for you. I'm Vandana from UK. After repeated sampling from the specific lymph node, do you see any change in your elastography because of a bit of nodal bleeding that may be occurring?
Yes, sometimes you see changes after several punctures, especially if you have a necrotic lymph node. You can see the channel where the needle passes. Even with the Doppler, you can see that a small amount of blood is coming inside. So if you observe very accurately, you can see some changes in the lymph node after the puncturing, either elastrographically and also with a Doppler mode. Again, usually this happens in big necrotic lymph nodes. There is a lot of something inside.